So again, my name is Lindsey Peterson, and today I'll be talking about counseling strategies in primary care. Okay, so an overview of what I'm going to be talking about today. I'll be going over some theories of behavior, what are helping conversations, so talking a little bit about that, motivational interviewing and substance use, the 5 principles of motivational interviewing, the 4 processes of motivational interviewing, and the OARS communication skills. So why are counseling strategies important in the primary care setting? So primary care clinicians may be the first resource for patients with substance or opioid use disorders. Comorbid health issues often cause individuals to seek care in the first place. Intervention by a primary care clinician may help motivate the patient to seek further treatment. And one counseling style called motivational interviewing has become an important tool for clinicians to engage with patients. It can help patients feel empowered to seek and maintain treatment. So going into some theories of behavior, I'm going to be talking about ambivalence and the righting reflex. So most people who need to make a change are ambivalent about doing so. If they weren't ambivalent, the change would likely already have been made. So they may see both reasons to change and reasons not to change. This is a normal part of the change process. People who have a substance use disorder or opioid use disorder are likely well aware of the downside of their behavior. They can describe the benefits of reducing or stopping that harmful behavior. So ambivalence occurs when an individual wants 2 incompatible things. For example, they might want to reduce their drug use, but they don't want to have to lose friends or go through withdrawal, etc. So when you have an ambivalent client, you will hear 2 kinds of talk mixed together. The first type of talk is called change talk, which is the person's own statements that favor change. And the other type of talk is called sustain talk, which is the person's own arguments for not changing. Both occur naturally, often within the same sentence. So you may hear, I know I need to cut down on my heroin use, but I've tried everything and nothing has worked. So that sentence has both of those types of talks mixed together. So helpers, such as doctors, nurses, counselors, etc., want to help get clients on the road to health and wellness. But this may lead to what we call the righting reflex, which is defined as the desire to fix what seems wrong with people and set them promptly on a better course. So what happens when you have an ambivalent client and you add in that righting reflex? So remember, arguments both for and against change already reside within the ambivalent person. So when a helper communicates the good side of the argument, a natural response is the client providing that sustained talk or the reasons not to change. So the helper might say, you have a serious heroin problem and you need to quit. Ideally, we would hear the client say the following: you're right, I didn't realize how serious it is. I'm going to quit today. However, the more likely response is, no, I don't think it's that bad. So when you argue for one side and the ambivalent person is likely to defend the opposite or provide that sustained talk. So this is the normal nature of ambivalence. It's not the client being in denial or being oppositional. So to reiterate, most people tend to trust their own opinions first and foremost, more than the opinions of others. Causing someone to verbalize one side of an issue tends to move the person's opinion in that direction. So if a helper is arguing for change and the client is arguing against, this is backward. The client should be voicing the reasons for change. So moving on to helping conversations, these lie along a continuum. On one end of the continuum is a directing style. The helper is providing information, instruction, and advice. They are telling someone what to do and how to proceed. So that might sound like, I know what you should do and here's how to do it. An example would be a physician explaining how to take a medication properly. On the other side of the continuum is a following style, where the helper is listening, seeking to understand, and refraining from inserting their own material. I will let you work this out in your own way. An example would be simply listening to a friend speak. So in the middle of this continuum is a guiding style. which is listening. The helper is listening and offering expertise where needed. So an example would be traveling to another country and hiring a guide to help you. The guide does not tell you when to arrive, where to go, what to see, or what to do, but they also do not just follow you around wherever you happen to wander. So motivational interviewing lives in this middle ground, incorporating aspects of each. So what exactly is motivational interviewing? It is a treatment strategy developed to enhance motivation for change. It emerged in the context of addiction treatment. It has a strong empirical support in trials with a number of substance using populations. It's been broadly applied in a range of substance use treatment settings due to its empirical base, short-term nature, and the overall goal of improving client retention and treatment outcomes. So some additional definitions of motivational interviewing. It's a collaborative conversation style for strengthening a person's own motivation and commitment to change. It's a person-centered counseling style for addressing the common problem of ambivalence about change. So moving into the 5 principles of motivational interviewing, the first is expressing empathy through reflective listening. So this communicates respect for and acceptance of the client and their feelings. It encourages a non-judgmental, collaborative relationship. The second is to develop a discrepancy between the client's goals or values and their current behavior. Separate the behavior from the person and help your client explore how their personal goals may be undermined by their current substance use patterns. Amplify and focus on this discrepancy until the client can articulate consistent concern and commitment to change. The third is to avoid argument and direct confrontation. Trying to convince a client that a problem exists or that a change is needed can precipitate resistance and even arguments. The goal is to walk with clients, not drag them along. The fourth is to adjust to client resistance rather than opposing it directly. Resistance is a signal that this client is viewing this situation differently than you and that you may need to change direction or listen more carefully. Continue to express empathy and remain non-judgmental and respectful, encouraging the client to continue to talk and stay engaged. And the fifth is support self-efficacy and optimism. So many times clients do not have a well-developed sense of self-efficacy and find it difficult to believe that they themselves can begin or maintain behavioral change. So therefore, it's beneficial to recognize the client's strengths and bring them to the forefront whenever possible. Improving self-efficacy requires eliciting and supporting hope, optimism, and the feasibility of accomplishing the change. So the next is the 4 processes of motivational interviewing. So these form the flow of the motivational interviewing conversation. So the first is engaging. This is when both parties establish a helpful connection and a working relationship. It's also often called a working alliance. This may occur in seconds, or it can take weeks to develop. So some questions to ask yourself are, how comfortable is this person talking to me? How helpful and supportive am I being towards them? The second is focusing, which is the process by which you develop and maintain a specific direction in the conversation about change. Some questions are, what goals for change does this person really have? Are we working together with a common purpose? The next is evoking, which involves eliciting a client's own motivations for change. When there's a focus on a particular change and you harness the client's own ideas and feelings about how they might go forward and make that change. So some questions to ask yourself, what are this person's own reasons for change? Am I steering too fast or too far in a particular direction? And the last is planning. This encompasses both developing a commitment to change and formulating a specific plan of action. So this conversation about action can cover a range of topics. And you can ask yourself, what would be a reasonable next step toward change? And what would help this person move forward? So moving on to the OARS communication skills. These are flexible and strategic core communication skills within MI, but they're also shared with many other forms of counseling. And they are used early and often throughout the motivational interviewing approach. So the O stands for open-ended questions. These elicit feelings about a given topic. They facilitate dialogue. So an example of an open-ended question is, what are the good things about using heroin, and what are the not so good things about using it? The A stands for affirmations. These support and promote self-efficacy, and they validate the client's experiences and feelings. They also help the clients feel confident about using their own inner resources to take action and change their own behavior, emphasizing past experiences that they have demonstrated strength and success can prevent discouragement. So for example, you might say, you handled yourself really well in that situation. The R stands for reflective listening, which is demonstrating that you have accurately heard and understand a client's communication, and it's checking rather than assuming that you understood. So that might sound like, it sounds like you want to cut down on your heroin use, but you aren't sure how to start. And the S stands for summarizing, which is distilling the essence of what a client has expressed and then communicating it back to them. So you're reinforcing what has been said, you're showing active listening, and then preparing to move on. This also links the client's positive and negative feelings about substance use, and it can facilitate an understanding of their own ambivalence and promote an awareness of any discrepancies. So that might sound like, here's what I've heard from you so far. Tell me if I missed anything. So hopefully I've covered motivational interviewing broadly enough to be applicable to each of your areas, most notably with opioid or substance use or addiction, but also it can be applicable with depression, anxiety, etc. And I also hope to have conveyed why it's important that we involve the client in the decision-making process. So wrapping up with this quote, the expert approach is quite appropriate in acute medicine, but when the goal is personal or behavior change, this approach usually breaks down. Personal change requires the individual's active participation for the change process. So lastly, I included some resources if this is helpful. Primarily, it's training opportunities throughout Wisconsin, and I also included some reading materials at the bottom, if that's helpful as well.
Thanks a lot, Lindsey. Any questions? And these slides are available on the website, correct?
Dr. Brown, this is John Glover.
Yeah.
Yeah, I'm wondering, Lindsey, I don't know if you'd allow me to have you elaborate a little bit, given that Dr. Brown, I think, gave us a great example. We have a client here who, on the one hand, wants to stay out of jail and wants to stop using cocaine, but he continues to use cocaine. Could you give us an example of how you might use this in a situation with a client like that?
Yeah, that's a great. So I think kind of exploring what's maintaining that cocaine use, because obviously avoiding jail, I think, is a pretty big deterrent. That's probably really motivating for this individual. So something is strong enough that's keeping that cocaine use occurring, whether that's developing into an actual physical addiction where they're unable to stop, or if it's those behavioral components that you mentioned, like the injection use. So maybe kind of exploring that and seeing, like, knowing that avoiding jail is probably super important to this person. So what is so strong that it's maintaining the cocaine use, and really exploring that, I think, would be helpful.
If I could just add, Dr. Brown, I don't know if it sounds like you're probably comfortable with this, but I often share my own emotions with a patient. So when they tell me something like that, I say, gee, I'd be kind of anxious if I were you, still using cocaine and really wanting to stay out of jail. That would make me a little nervous.
Right.
How are you feeling? And so I'd kind of let him borrow some of my emotion a little bit around that.
That's good.
How often do you check in and summarize? It seems like you could take up a lot of time reinforcing and I'm not sure how often you think that that's needed within the conversation.
I think the summarizing is most importantly used when you feel like you've kind of explored a general topic. You feel like you might be kind of going in circles, and that it would be more helpful to move on. So a lot of times if a client is just continuing down this path. You've explored everything, and it might seem not as helpful anymore to continue down that path. Kind of redirecting in a way by doing that summary where you're saying, okay, this is everything I've heard from you. Does this sound right? Okay, let's prepare to move on to a different topic together. So it's kind of like a respectful way to check in and make sure that you've heard everything that they've communicated with you, but that you respect their time and you want to move towards a conclusion or a plan of action. So that's a good question.